Everybody in from the lobby here in just a moment. So good morning, everybody. We're letting everybody on in from the lobby. So we'll give it just a moment or two for everybody to join in. My name is Dominic Zerlo, and I'm the Center Director for Medical Cannabis and Psilocybin. This is the Research and Continuous Improvement Committee from the Medical Psilocybin Advisory Board, and Dan Jennings is the chair for this committee. And so just as a reminder to everyone, because we've gotten the question again a few times, the reason why we have all of the cameras off except for some of the presenters and some of the staff at Department of Health is for two reasons. One, because we want to ensure there's enough bandwidth for people who are in more rural areas or other areas where internet may not be as strong. We want to ensure they have enough bandwidth to stay in the meeting, at least for as long as possible. And the second reason is, and this hits not just from a visual, but also from a spoken word aspect of it, is please remember to make sure that what you say is appropriate for recordings, because we do record these and post them up on the website, so they are available for the public. So please make sure that you're using appropriate language. And that's the other reason why we have cameras off, because sometimes unbeknownst to people, there are things in the background that we otherwise have to blur and bleep out. And so we prefer not taking the time on that and focus on the work itself. In any case, thank you everybody for joining. With all of that and the reminders, I will turn this on over to Dan. Dan, this is your meeting.
Thanks, Dominic. Appreciate that very much. And I'm real happy to have everybody here today. Thank you all very much for coming to the Research and Continuous Improvement Subcommittee. Appreciate your being here today. We'll be going from 9 till 11, and I just popped the agenda up a little bit earlier, but during this first part of our agenda, we always do our announcements and introductions, and I would love to have everybody kind of introduce themselves. A couple of things that we would love to do is do that with your hand raised there. We'll get to call on you, and in the meantime, while you're getting to that point, I know that we've got a few of our board members on today, so definitely wanted to call them out. I see that Ian is here, and I believe that Brenda's here as well. So while everybody's getting their hand raised to do introductions, I would love for the DOH team, if I'll turn it back over to Dominic real quick to see if there's anybody that he'd like to call out on the DOH team, introduce, and if there's any announcements also there.
Yeah, thank you, Dan. Good morning again, everyone. And so today from our Department of Health team, we have assisting us is Johnny Mouche, who's going to help with the muting and unmuting for people as they speak. We have our psilocybin program manager, Jorge Gonzalez, is joining us. We have our compliance officer, Leslie Peterson, our environmental scientist, Cyrus Routman. We have our medical director, Rob Truckner. We have one of our health educators, Adrian Estrada, who is also present. And then we have a few other staff members who help us with regard to other areas, including from administrative and financial. We also have our finance coordinator and director, Selena Montoya, who has joined in. And I think that's everybody that we have from DOH. If I miss somebody, my apologies. But otherwise, I'll turn it back on over to you, Dan.
Awesome. Thank you all very much. So remember, for your introductions, just let us know your name, your location, where you're coming in from, any affiliations that you might have. And if this is your first time, or if you're returning, remember, just raise your hands. And whenever you're called on, you'll be unmuted, and then you can open your microphone up and speak.
All right. And just as a reminder that to raise your hand in Teams on the top banner, there's an icon with a hand that says raise. And also, if you'd like to introduce yourself in the chat, you can do that as well. Looks like first we've got Don Moser. And Don, I have enabled your mic. You can unmute when you're ready.
Good morning. My name is Don Moser. I live in Las Vegas, New Mexico. I'm not affiliated with anyone. I'm just a very interested party, and I enjoy learning about this new program. Thank you so much.
Awesome. Thank you, Don. And next, we've got Brenda Burgard. And Brenda, you can unmute when you're ready.
Good morning, everyone, and welcome newcomers. I am Brenda Burgard, and I chair the education and training for the advisory board here for the medical psilocybin. So welcome, everyone. Thank you.
All right, and next we've got Kate Hawk. And Kate, you can unmute when we're ready.
Good morning, everyone. Kate Hawk. I live in Santa Fe. I've got a background in trauma therapy, psychedelic therapy, therapist training, harm reduction, Native American communities, and particularly interested in end-of-life care.
Awesome. Thank you, Kate. And next we've got Sky Rivers. And Sky, you can unmute when you're ready.
Can you hear me? Did I do it right?
Yes.
This is Sky Rivers. I am with the Santa Fe Reporter. I am covering ongoing news coverage on this topic. Very grateful to be here. I'm also a retired intuitive counselor. Thank you very much.
Awesome. Thank you, Sky. And next we've got Denali Wilson. And Denali, I've enabled your mic. You can unmute.
Good morning, everyone. My name is Denali Wilson. I'm the Director of Strategic Support for the Healing Advocacy Fund, which is a nonprofit that supports state-regulated access to psychedelic healing. And I have not been at this committee for a while, so grateful for the opportunity to reintegrate.
Awesome. Thanks, Denali. And next, we've got Dr. Lita, I think Fatemi. It's showing up as Fatemo today, but I'm pretty sure that you're still the same person.
You're right. I mistyped and then it took it and I was like, oh, I can't edit it. Thank you for noticing the typo. Yeah, I'm Dr. Lita Fatemi. I'm an academic physician, founder of the Conscious Physician Psychedelics Academy. And I'm also a hospice physician with ABQ Hospice and Palliative. And I love what I do and I love being here with you all. And it's wonderful. Thank you for doing what you do.
So thank you. And next we've got Ian Dunn.
Good morning, everyone. My name is Ian Dunn. I'm the chair of the Medical Psilocybin Advisory Board. I'm just happy that everyone could make it today and happy to participate in any way I can.
Awesome. Thanks, Ian. And next we've got Danielle Leonard. And I have enabled your mic and you can unmute.
Hi, I'm Danielle Leonard. I live in Santa Fe. I research with New Mexico Highlands University, and I'm a therapist focusing mainly in acceptance and commitment therapy.
Awesome. Thanks, Danielle. And next we've got Catherine Warnock. And Catherine, I've enabled your mic. You can unmute.
Good morning, everybody. My name is Catherine Warnock. I am located in Las Cruces. I am a psychedelic therapist. I've been doing this work for years, and I'm just excited to be a part of this. I've really struggled to attend this particular meeting just because I've had a lot of conflicts, but I finally am here, so I'm excited to be a part of it. Thank you.
Awesome. Thanks, Catherine. And next we've got Gregory Evans. And Gregory, I have enabled your mic.
Good morning. My name is Gregory Evans. I am an independent researcher and home mycologist based out of Santa Fe, New Mexico. Yep, that's about it. Good morning.
Good morning. And next we've got Shin Sonia. And I have enabled your mic.
Oh, good morning, everyone. My name is Sonia Shin. I'm with the Office of Alcohol Misuse Prevention at New Mexico Department of Health. I'm a physician. I see patients in Gallup, and it's my first time attending the committee. So excited to be here. Thank you.
Awesome. Thanks, Sonia. And next we've got Teresa Bertonsen. And I have enabled your mic. You can unmute when ready. And just reminder for unmute, there is a icon at the top banner that says mic that you'll have to click on there to unmute. Sometimes if no mic is selected, there's a drop down next to it as well that you might be able to select a mic that will work. And if not, maybe just try dropping something in the chat. And if all else fails, dropping off the meeting and then rejoining will sometimes fix those issues as well. All right, so looks like Teresa might still be having some issues. So next we will go to Jay Webster. And Jay, I have enabled your mic. You can unmute when ready. Sorry.
Hi, my name is Jarvis Webster. I'm a New Mexico resident. I live in Hidalgo County. I grow gourmet mushrooms, and I want to see if I can help with this program.
Awesome, thank you. All right, and I think that was all the hands that we had up. And we've got some introductions in the chat as well. Let's see. I can go ahead and read those as well. We have Nifa Naya Washington with us from Santa Fe, co-director of Psychedelic Mental Health Access Alliance. We have Carolyn Crowland from Atlanta, Georgia. This is her second meeting and is affiliated with Fireside Project. We have Eileen Brewer. Let's see. She is sick. I'm sorry to hear that, Eileen. Community organizer and psychedelic educator for more than 10 years. Work with Cluster Busters and have worked with the Psychedelic and Pain Association and helping with patient and community education on this committee. We got Shane McDaniel, integration coach and hopefully future cultivator. Clovis and Logan. And Jessica Eden, LCSW, psychedelic assisted therapist in private practice in New Mexico and Colorado. And this is her first meeting. Welcome. All right, and back to you, Dan.
Thank you all, everybody. Appreciate it. And it's great to see a lot of returning. And for those of you that are coming for your first time here, really appreciate you being here. This is actually a really good audience. So thank you all for coming out to this meeting today. Got some, I think, really exciting things that's going on with this group. Our intersessional work groups have been doing amazing things. And I really appreciate their time. James Brown, Gregory Evans, Danielle Leonard, and everybody that has been helping to come together with some of the recommendations for this committee have been fantastic. And so one of the things that we'll be looking at here for our next wave here is just to hear kind of work group report outs. And then we do want to do some, in this meeting, a little bit of clarification of what other committees are working on and doing. And so that way we know our role as it is for support for those other committees. So I've done a little bit of breakout of some of the things that our committee is tasked with, what other committees are working on because they're doing that actual work, and what our committee is kind of responsible for to be that support for those activities too. So hopefully that'll kind of clarify a little bit. And it's great to see Ian and Brenda here on the call too. So I'm hopeful that they'll be able to kind of chime in as well on some of the things they're working on in their committees, because with a lot of y'all that are here, I know that your heart and passion fits in with a lot of those committees, and hearing your introductions really means that I want to make sure that crosswork happens there. That way we'll be able to clarify if it stays in the RACI committee. And then I do want to, I've kind of done a little bit of work on what we can do in the RACI committee to break up this work, hopefully for our next sprint priorities, and kind of line out over the next set of months kind of what that might look like. So I've done a little bit of splitting things out. I'm hopeful it might help, and we'll just kind of see where it goes. Love to hear your feedback. Always raise your hand if there's anything. We'll be able to call on you, or drop it, of course, in the chat. I can see the chat going too. So if you do put something over there, make sure that you just put it in there so we can see that. So our first kind of sprint is going to be our intersessional work group report outs. We did have 3 committees. We have an outcome or challenging events, adverse expense monitoring reporting. We have emergency preparedness and response recommendations, and patient and community education recommendations. And so I know that I saw Danielle on and Gregory on. I didn't see James on, but I'll kind of turn it over to one of you, both of you, so that you can just kind of like share out in this time what has been happening and what y'all have been meeting on, and things that have moved forward, things that might be stuck, things that we might need to work on. So I'll turn that over. And Gregory or Danielle, if you want to raise your hand, we'll get your mic opened up for you.
Cool, let's see, and I can let's see, allow your mic. Do you have anything you were going to present either, or like from your screen?
I do. I can send it in, or I can present if that's okay.
No, yeah, I'll just raise you to presenter.
Yeah, and I'll go ahead and
no
stop
yellow
the share.
buttons.
Right, exactly.
That's right.
No, don't
So
press the
push-
yellow button.
Don't push the yellow button. James is away. He had to go pick up his kids from college on the East Coast. He mentioned that he was going to try to call in, but he was not sure about service. So I've agreed to kind of take care of this part. Danielle is with us. Are you on mic, Danielle?
Hi, yes, I'm here, and I can speak to the reporting, multicultural reporting for the RACI group, from our work group.
Awesome. Give me 1 second to figure out how to present slides. How do I switch this? Well, I guess swap. There we go. Now we can. Bear with me. I was hoping to have a few extra minutes. I just walked in the house.
I know. I was. That's why I always like. Okay, are you ready? I'll stall. So that's okay.
Nope, I'm here. I just need to get this presented.
And actually, while you're doing that, I'll go ahead and read one introduction. So, Teresa, I apologize. I think I'm going to butcher your name. I apologize. Bertonson. I apologize if that was not the way you pronounce your name. I cannot enable my mic. I'm Teresa Bertonson, LMFT, LPCC. I live in Taos and work in Los Angeles, New Mexico, and Hawaii. I am a trauma therapist, consultant for multiple treatment teams. I am a EMDRIA approved consultant and trainer. I have completed the MAPS and CIIS training in psychedelic assisted therapy and research. I'm part of a small team of psychiatrists, physicians, and clinicians who mimic psychedelic therapy clinical trials for research presentations. So Teresa, thank you for being here. And on over.
Okay, is that slide up?
Yes.
Cool. I want to take a minute to appreciate Danielle Leonard for being here, the work that and insight that she's contributed to our little, and it's not a gang, it's just like a group of nerds. It has been instrumental. I'm going to burn through the, on the top half of it, just a quick little introduction, go through the emergency preparedness stuff, and then hand it off to Danielle as we go through her stuff. And if I need to kind of like help navigate the slides, we'll do that. We have been working on a number of things, and we'll kind of expose where some of those things are and what kind of help that we need moving forward and what gaps we could use help unblocking. James was kind enough to volunteer us for picking up the emergency data. And so one of the things that we did was we looked at it from terms of outcomes reporting, and we went in and found research defining the existing reporting research on what have been termed as adverse events, emergencies where emergency medical institutions have been engaged. Two major seminal publications, Copra et al. 2022 and Simon et al. 2024. The first one is EMT engagement, and the major revealing factor for when you isolate it down to psilocybin, or it's not even psilocybin, it's just mushroom use, is that it was mostly young men that were having challenging experiences. Like, if as you read through the lines, there's one in 1800, and the the data in that paper is very revealing. Simon et al. Is a poison center mushroom exposures from 2013 to 2022. It's a 10-year study. The major outcomes were 4.2% compared to 43% for moderate outcomes. The thing that we saw is after 6 hours, most people had fully recovered, and by 7 days, 100% of the people had recovered from their experience. The number of pediatric exposures was 409. One of the things that I wanted to point out in this is that there was no definition of like how those pediatric cases were introduced to the mushroom, whether it was like poor storage or whether it was toddler eats mushroom in yard. There's no disambiguation in that study to separate those types of things. Overall, the substance identity was completely unconfirmed across all the studies. Dosage was unknown, and therapeutic context was not considered. Breakdown between psychological and physiological engagement is kind of interesting. The psychological stuff, all of our well-trained facilitators and practitioners in the industry will find that those are commonly misunderstood conditions, whereas the physiological conditions, tachycardia, nausea and vomiting, high blood pressure and seizures, with passing out being like the highest percentage on that. It's interesting to kind of read that data and see what it is. The caveat on seizures is those cases were all connected to trazodone medication. As far as, sensitive mouse today. And please let me know when I start to run out of time, because we've got, let me know when I hit 5 minutes. Medical interventions generally involve IV fluids, benzos, antiemetics, and very rarely intubation. There's very little like specific data about where those ventilation and intubation instances occurred. It's probably worth investigating, but low priority as we continue to look through the data. The main thing that our group has been focused on is trying to figure out a way that when we approach reporting outcomes on what are considered adverse experiences, we're able to filter out challenging experiences from adverse events. The primary instruments that we're utilizing to follow challenging experiences is the CEQ-26, and it has a number of paired instruments that augment it. And then for adverse events, our primary goal is to find a way to either A, adopt the PATAE into our reporting structure, or to modify the pro-CTCAE. If we do, and we'll talk about this a little bit later, if we do adopt the pro-CTCAE as a modified structure, we're basically just going to fold the PATAE into that. Essentially, what's not built is the screening protocols, collection workflows, and the reporting forms that operationalize all of the above. The targets and instruments are defined, but the implementation is essentially the deliverable that we're hoping to get to by the 11th hour. On to multicultural competency. Danielle, I have laid out some slides. If for any reason you need me to jump around, please just let me know. And if you want me to talk and jump in, I can handle that as well.
Okay, cool. I actually have some slides as well.
Oh, take over.
Okay.
Please, because I am still editing these. Let me jump out. I love that. Thank you so much.
All right. I'm gonna elevate you, Danielle. So yeah, like we were saying, just don't press the yellow button that says end meeting. But other than that, let's see.
Oh, I see. I see.
Cool. Do you have a little icon that says share next to that?
Yeah, I'm pressing
Okay, cool.
share
Very
and
carefully.
browse my computer. No. How do I go on online with it?
So there should be like a thing in the share. If you've got a window open in your browser that has what you want to show, that should
Yeah.
be available in the window section where it should say window and like maybe like a number in parentheses, and whichever window that you're looking for should be in there.
Fabulous. All right.
Sweet. We can see multicultural competency in psilocybin services.
Yeah, so let me go to the next. Gregory already covered us. This is the presentation on our cultural research findings. I just wanted to explain that we're the RACI committee, so we're doing reporting, but we ended up having to cover everything across the whole program because what we're reporting on has to be embedded in the program, so we know what we're measuring. So fortunately, with professional training, we don't have to reinvent the wheel. Training in multicultural care has grown across behavioural health professions over several decades, especially in graduate programs. Since 2002, the APA Ethics Code, with standards 201A and B on boundaries of competence, requires practitioners to work only within areas of demonstrated competence, and that includes cultural competence. Also, the APA multicultural guidelines that were adopted in 2017 extend this across all domains of practice, research, and education. So these can be adopted directly into our program certification. And here I'd like to say, I'm sorry, I haven't managed to get to the training and education committees, and I hope to be enlightened very, very shortly. So graduate training for therapists and counsellors shares a framework organised around awareness, knowledge, skills, and action. There's also a text that's used extensively in graduate programs called Counselling the Cultural Diverse by Sue et al. For accredited counselling and psychology programs. And it covers awareness of all of our own individual values, biases, and worldview, having knowledge of diverse client backgrounds and worldviews, skills in culturally responsive intervention and communication, and more recently they added action to encourage people to actively work toward equity and inclusion. So my point with all this is that the field has already established clear baseline over for multicultural competency training, and this can be used by our program and for people, particularly for people who haven't had formal training, or for everyone really. Typically, multicultural competency covers race and ethnicity, gender, socioeconomic status, sexual orientation, gender identity, religion, spirituality, disability, immigration, language, and intersectionality. And there's a list of what's generally covered in training: the cultural humility, bias awareness, religion and spiritual diversity, the intersectional, everything I just covered basically. And of course, psychedelic psychotherapy adds another dimension that requires additional awareness and training because material surfaces at a heightened depth and speed, as we all well know. And it includes strong emotions, trauma, And these are the heightened sensitivity. So the stakes around cultural imposition are higher than in standard therapy sessions. So in this context, multicultural competency isn't just about respectful communication. It includes a sensitivity to worldview, spirituality, language, music, symbolism, participant autonomy, and agency. So Gregory mentioned Politsky et al. He's got a couple of papers I refer to here. He's got a comprehensive framework for adverse events in psychedelic psychotherapy that I think our group thinks will be very helpful for this program. He notes the importance of spiritual, existential, religious, and theological dimensions in psychedelic care. And he has identified a very wide range of adverse events with direct multicultural relevance. I'm not going to read them all off, but a couple that really interested in me was spiritual. One, the spiritual and religious injury, which includes the resurfacing of prior religious abuse. And Politsky flags this, and the therapist facilitate a tendency to reframe all difficult experiences as growth, particularly in psychedelics. But he's clear that this can result in genuine harm going unacknowledged and unaddressed with regard to spiritual or religious injury. He also talks about culturally neutral therapeutic frames that aren't actually neutral. One that's really interesting is the idea that therapies present themselves as culturally neutral when they're not always. Like CBT is shown to have a poor cultural fit with some Native American populations because of its assumptions around the self, rationality, don't believe everything that you think, and it doesn't always align with other cultural values. So in considering all this, our recommendations for collecting data follow from that. So first of all, multicultural competency should be a certification requirement for everyone involved. Second, participant preferences need to be assessed during preparation. Politsky, one of the things he says a lot is we ask rather than assume. That would encompass framing music, cultural concerns, and prior harmful materials. Third, we need in-session protocols. Bell et al. Says that training matters, but that many psychedelic manuals and practice guidelines still under-address culturally responsive behavior during the session itself. Fourth, therapeutic congruence. This is something Gregory's really worked on a lot. So it's making a good fit between the client's preferences and the care model. Gregory talks about matching clients to practitioners where possible, not just matching a modality or therapeutic approach or framework. A client might feel safer with someone who shares their cultural background or who has general cultural knowledge or speaks their first language. Of course, a perfect match is not always available, but it can be a goal. And lastly, the cultural framework connects directly back to the research program. We need brief, practical data collection at every stage of the process. So this is our proposed reporting pathway. It follows the treatment process we've been talking about. So a therapist preparation report would capture what was learned about the client before the session, what are their preferences, risks, sensitivities, what's their readiness. A facilitator session during the session would capture what's actually happening in the room, what approach was used, what cultural or spiritual material arose, were there any distress or boundary issues. And then therapist integration notes would ask, how did the client's cultural and spiritual framework shape their meaning making, and were there any concerns? And then a client post integration feedback would capture, Did they feel respected? Did the care match what they asked for? And were there any harms? So this data can all evaluate whether multicultural competency is actually being delivered, and it can be brief enough not to create a lot of burden and still capture what matters. So we had a little meeting before here, and Desba came to it, which was fantastic, and she gave us some excellent feedback, and I thought it'd just be good to share some of her comments and a bit of our response. She noted that the language of research is very academic, and it is, and I know that that can be, exclusionary for different stakeholders. And research does tend toward academic language, and this is the RACI committee, so it's not surprising. But these concepts can all be expressed in ways that feel more culturally grounded for the communities we're serving, and it'd be great if other people wanted to take it in that direction. She also talked about the spiritual landscape and the wide diversity of cultural and spiritual traditions here in New Mexico. The dominant frameworks in psychedelic culture might not always reflect them. There's quite a list there that goes beyond, the commonly talked about white, Hispanic, Native breakdown here. And then she also spoke about the complexities of cultural identity. She mentioned that participants often carry multiple cultural influences, and that sometimes they're only partially connected to their traditions, which could be emotionally challenging for them, or they might not have a settled spiritual or cultural identity. So this comes back to the importance of the therapeutic relationship and cultural sensitivity of the therapist, and the program framework. So all of this brings up a lot of different questions. I've mentioned 3 here. Importantly, how does this work that the RACI committee doing connect with what the cultural and training and education committees have already developed? We don't want to duplicate work or build in a different direction. And as I said, I haven't had the opportunity to meet with them. And then the question of cultural exchange versus extractive practice. So I know many facilitators draw on Indigenous shamanic traditions and have trained with Indigenous teachers, but is lineage training sufficient? Or are there broader obligations around attribution, benefit sharing, and community consent? Celadwin and his colleagues have done important work on this with 8 ethical principles that include benefit sharing, community consent, and reparation. And then lastly, I can talk more about this if anyone's interested, or I think I've got the paper at the end in the bibliography. But lastly, who's missing from the room? The literature is consistent that psychedelic research has been shaped by a narrow demographic. And as we build the program, I think this is a question worth sitting with. So this is a brief look at the core issues involved in multicultural competency and psilocybin services. We have the professional and ethical baseline, the particular considerations of psychedelic therapy, what the adverse event research tells us, and some starting recommendations for reporting and data collection. I just want to say each of these areas has an extensive research base. The Politsky Adverse Events Framework could occupy a full session. The Indigenous knowledge and cultural exchange question has a rich and actually quite contested body of scholarship. But we've kept this deliberately wide angle so that we can keep it open for discussion. And I'm happy to share this paper with anyone who wants it. But one very last final thought. New Mexico Department of Health has a real opportunity here because much of the existing psychedelic research has been shaped by white university student samples. And even though more recent clinical trials have included older participants, the samples do remain predominantly white, which is a well-documented limitation in the literature, and it significantly constrains how generalizable the findings are. So with this psilocybin program built with multicultural competency at its core, that can serve a genuinely diverse and underserved population, it can produce research that reflects this genuine diversity, and it'll be a meaningful contribution to the literature, and it won't have already existed in the field. And that's going to open up funding opportunities, because multicultural and health equity research continues to be important priorities for federal and grant funding, although I think the federal policy landscape's changing. But opportunities can flow through the state, through places like SAMHSA, affiliate researchers through NIMH and NIDA, and through private foundations like HEFTA and USONA, or through state appropriations. And that means the multicultural piece is not a cost to this program. It's a long-term asset. So thank you.
Thank you very much, Danielle and Gregory, both of y'all, for really rooting everything that you brought back to the committee and research. And this was fantastic. I really appreciate it. We've got
Dan,
about
do you mind if I end cap that really quick? I know we're short on time.
Well,
right.
No, it's fine. We got 8 minutes for the comments for everybody, but yes, please go right ahead.
Yeah, I'll take 30 to 45 seconds. Basically, the outstanding, like the comment, some of the major comments that we need from the committee is to approach one of three potential pathways. Either we want to adopt a PATAE, or we want to authorize pro-CTCAE with the adaption clause allowed in that instrument, or we want to make a concerted effort towards reaching out to Emory and Politsky to really answer those questions about what their position on our adoption of that is. I also wanted to make note that the Circle of Care organization has been implementing a lot of these culturally informed and identity enriching and embracing parameters in their model. And I know that they're already connected into the framework of this program, but I just wanted to honor like the work that they've done before any of us even thought about coming into the room. But yeah, thank you.
Oh, Dan, you're muted.
Yeah, perfect. Thanks. Yeah, I said something very important. No, Gregory, thank you very much on that. I think that toward the end of today's session, let's go ahead and make sure that we get a lead on your question about do we move forward on the PATAE or the pro-CTAE. So that's a perfect thing to hit before we exit this meeting today. So thank you. And we have about 5 minutes before our next beat, which is cross-committee alignment, which will be a perfect time for, I know that Brenda's here and Ian is here. I would love for both of them to be able to share with this committee some of the things that y'all have worked on through your committees and where this kind of comes together with us. Some things that might go back to your committee, some things that you could leave with us as well. But anybody that would like to make a comment during this time, please make sure you raise your hand, share. This will be about what we just heard from both Gregory and from Danielle. So please go right ahead.
I see Brenda's hand up.
Hello, everyone. Thank you. Danielle, you did a wonderful job kind of pulling everything out and taking a really good close look at this and what we're looking at here, because this is exactly what I think mostly we've been struggling with is the multicultural aspect of bridging this gap between, the predominantly white culture and the medical medical program that is kind of set up here, and bringing this in. This is a really important part of what we are here in New Mexico. And I think as we keep this multicultural part open, it keeps us also growing in this arena to include everyone in this, and actually um, giving it more space, more understanding, and incorporating some other things that maybe that we're not seeing right now. But this is exactly what we've been needing in this program, because I think this is where maybe other programs have just kind of maybe touched on or, glanced over. But, thank you for doing all of this work, because you really dove into all of the research that is there right now. And this is so important, because I think New Mexico is very different in this, in bringing all of this knowledge in, and it still continues to grow. I mean, we're learning as we're actually looking at some of this material and reading about it and trying to formulate something. So thank you again for bringing this to light.
Thanks,
You're
Brenda.
welcome.
Appreciate it. It's fantastic. And Ian.
Perfect. Yeah, I just wanted to also say thank you guys for this presentation. It was really nice. I have definitely tried to make us as culturally competent as possible, because I think we need a generalized return in medicine to patient preference. And oftentimes that gets overlooked in our current medical system, and they'll just say, well, this medicine works best, or this situation is what you're supposed to do. And so often, is that not the best scenario for every patient? It's not, we shouldn't be using blanket recommendations. So the ability to take time and just recognize their different starting points for each person, in terms of their cultural heritage and what they've experienced, I think is a very great example. I also want to reiterate what they were saying before, in that we do, a lot of the research is concentrated in one race group. And so we have the opportunity to return this medicine back to the communities that it had thrived in, if they want to participate in the medical system. And I think that is a really great opportunity as well. And then just to provide my insight, I'm preferential to C2CAE, but this is my first time at this committee, so I am definitely not the one that should be making that decision.
That's okay. I appreciate, that's why I wanted you to be here to kind of provide. And actually, and I don't know, so if this is putting on the spot for anything, you could tell me, nope, skip this one. But is there anything from your committees that you wanted to share with this committee that might have come out from recommendations that your committees want to move forward that could help us in alignment with what y'all are working on?
So right now we have built a framework for risk stratification for patients. And so one of the things, while we are going to have to present a phase one based on the research that we have, when it comes to maintaining this program and ensuring that we keep up with evidence-based practice, I think a standardized collection such as CTCAE would allow us to update and keep it relevant to what people are actually experiencing when we take into consideration these other situations. I have rarely seen in a hospital a patient without a single comorbidity. It doesn't happen. You never have just one thing, unless they're very young. But so being able to study and say, okay, is this causing harm to people? Are we actually benefiting them? Are we throwing people, into the deep end? Being able to receive what they're actually experiencing, because another thing that is important to me to at least consider as we go on and as we continue to collect research is, when we had medical cannabis, the potency went through the roof. So I'm anticipating that the potency for psilocybin will also try to creep its way up. in one way or another. And so the ability to say, okay, this manufacturer or this facility is making something that is consistently causing, deep paranoia or some severe nausea, gastrointestinal issues, something like that, to be able to respond. Yeah, but that's all I had for right now.
Perfect, thank you. I know that Gregory will probably respond back on that, but I did want to see Dr. Fatemi's been waiting for just a second. So Gregory, if you'll hold that for just one moment, and Dr. Fatemi.
Oh yeah, please. Fatemi's actually in our work group.
Oh, perfect, great.
Fatema.
Yes, thank you so much. Thank you for the reminder. Yeah, no, thank you so much for this work. It's so important. And, I'm from a different culture and spiritual background. And I love how you guys are touching on all of that and including what we need here. Because, the research out there is just a lot. Some applies and some doesn't to our community. And I love, what Ian brought up, the idea of giving people back their power and agency. In fact, in our group, that's what we are constantly talking about, that each individual has agency and that we need to tell them that, hey, here are the tools, but I'm not the one walking this path for you. No one is, but the individual, and to give them options is so important to really evolve how the medical practice is implemented as we have it. So thank you so much for the work. I have to leave to tend to our academy. We have a lecture coming on, but thank you so much for this, and have a lovely day.
Thank you. Okay, Gregory.
I got distracted. Yeah, I kind of want to put. Yeah. Sorry, I kind of want to push back on the CATAE. If just to put a note in that, like, and I don't want to speak for the entirety of the work group, so I would appreciate Danielle kind of clarifying some of my statements that might feel harsh. But the CATAE is hands down dangerous to implement because it doesn't allow us to separate challenging from adverse events. The CATAE offers a pro version, which would allow us to modify the instrument to the context of our needs, but we cannot measure adverse events on a cancer treatment platform. We are very uniquely different. And so I'll post a link to the work and how it's framed so people can explore that, and I'll post that in the chat in just a minute. But the other thing that I wanted to kind of point out and maybe get a little bit, maybe encourage Danielle to talk about a little bit more, if we have time, is I made notes. Like the influenceability. So like when a practitioner comes in with their like subconscious framework and it doesn't align with somebody as sensitive as they are, like I had a very awesome conversation with someone in the community yesterday who like couldn't handle administering MDMA because they had a bad relationship with it. What they found later is that like their patients were having a bad experience because their psychological framework had like an unintended influence on that space. So the level of awareness that a person has maybe gates their ability to practice true sensitivity. So just in that back in that alignment space, I had another question for somebody, but yeah, please, Danielle.
Yeah, go ahead, Danielle. We got about 4 minutes left.
Sorry.
Go for it. No problem.
Yeah, no, I hear you, Gregory, with both those things. I think that's what the training is about. That's what the training is intended to do. Those first 2 points, cultural humility, which encourages ongoing self-reflection and openness to learning from the client. And then really particularly bias awareness. I went through these programs myself. It's a deep dive into what's my personal and systemic biases that might affect how I relate to other people, which is a process that students get put through and that the certification for this training program can do. And it's never going to be perfect, but you know.
The world's not going to be perfect. And I think just as important as like clinical handoff, like if you have a patient that is expressing a condition that maybe was masked or not disclosed, like cultural handoff is vitally important as well. If you find that you're ethically not suited for a specific treatment, like understanding your network and building relationships outside to bring in the appropriate care is something. Yeah. Anyways, we're bridging into guidance.
Exactly, but that's exactly what Danielle mentioned. It's the continuous improvement, and this is where Brenda and Training Committee can continue on to look at what additional professional development and those kind of things look like. But we can work together on those kind of things to report back out to these other committees. And I want to read into the comments. Ruben Sutter, MD, appreciate the presentation, agree with Dr. Fatemi and honor in importance to honor agency and autonomy for the individual seems central to the healing process. And so thank you for that intersessional work. We'll continue this. I'm going to continue this discussion as kind of what our next steps are going to look like here towards the end of today. But this is a perfect time to kind of talk about that cross-committee alignment, because there's a lot of parts that we work together with those other committees on. I really like the idea of how we can work together. So I've tried to kind of put together a little bit of a way that I feel, this is again feel, but is where I'd like to kind of go from, is that what our committee does and what other committees that kind of have a hand in what our RACI responsibilities are, and then the bidirectional work that we can do together on this. So some of the easiest things, of course, our committee is responsible for like data and monitoring. And so there's like 4 big things: the core data elements, the outcome monitoring, evaluation frameworks, and population level equity trends. So the idea that we look at is like, there are certain things that we do. That's what that second column is. These are the things that we'll be working on. But other committees that have kind of the lead in a lot of this include that third column there. So we want to make sure that as our other committees are coming up with rules and content, that we're mindful of those things and make sure that our committee for the data monitoring are looking at it. But what we can do, the bidirectional work in the fourth column then, is what we can work together on. So I'm not going to, like I said, I'm leaving this up on the screen so that you can read it or take a snap of it. And at the end, I'll have a link to this. But I just want that to be one thing that we kind of look at. Then we also have kind of a safety and harm reduction component to what our responsibilities are, including adverse event reporting standards, the harm reduction practices, risk screening, medication interaction and guidance, and emergency preparedness. Now, again, that crosses over dramatically with a lot of other committees, meaning we're not making the rules for those things. We're talking about what our committee can do when those rules and contents are being brought. So what can we do bidirectionally? We don't, for example, set the screening criteria, but we talk about what screening related data that needs to be in there. And so a lot of what Danielle and Gregory have already talked about is exactly that. So we're trying to make sure that we're respectful of the other committees' work, but what can we do from this committee? And then one of the last sets, of course, equity and ethics, a lot of exactly what Danielle had spoken about just a minute ago. from all the way from ethical practices, research practices, to informed consent, patient education, where again, other committees are responsible for that core content, but we are able to really be here to kind of share a lot of the research, which was exactly what we just saw today, which was fantastic to say, here's the research around that and the things that we need to be mindful of. And then the last thing, of course, feedback and continuous improvement. And that's really where we stand up the most, is that as the program really is operational and data and information is coming back in to the program, then this committee can really look at the process, the reviews. What we need to look at is whenever there's issues for safety and fit and mismatch and harms, and then make sure that that is bubbled up. And then if there's changes that need to be made to the program, what we can do. So as I just wanted to one of the last things from our last committee was just to make sure that for my mind is kind of, this is where I felt it made sense for me to line out, where kind of our Venn diagrams overlap a little bit, but where we kind of stay on course as to what we need to work on. So that's why I appreciate those of you that are on other committees and bringing some of that back to this. And if you are on those other committees, to take back to those committees some of these things too. I would love if there's comments, feedback, thoughts that you have about this part that I kind of shared. Please raise your hand and let me know so we can open your mic on that. And while you're doing that, if there's anything you want to add, I'll read from the comments. Eileen Brewer, since the last meeting, I've been focusing on the integration piece. And I've created a section in the document below, beginning on page 2. I connected with experts in integration in New Mexico to find out what they believe is most important to share with the general public, various communities, and those interested in medical psilocybin services. Next, I intend to focus on education in schools, as that was discussed at the last meeting. And I will be connecting with stakeholders who have considered this carefully. I also plan to focus on identifying communities that may need different kinds of messaging, veterans, BIPOC, et cetera. And there's a link to the Google Doc. And then Gregory posted, here's the core of Politsky et al. On the PATAE framework. And Eileen, unfortunately, I have to log off. Thanks so much for the great work. So just wanted to read that into the comments. Anybody that wanted to kind of share anything about, like I said, our work for the RACI committee and the overlap from other committees.
Cool. I see Denali's hand up. Denali, you can unmute when you're ready.
Morning again. And Dan, this looks like a really wonderful plan. Thanks for laying it out for us. I just wanted to offer, and I feel silly for not thinking of it sooner, but I've been working with, there's a cohort of 3 faculty between the School of Social Work and the School of Public Health at NMSU who were selected for the UPEP fellowship, which is a national fellowship for integrating psychedelic curriculum. Not in, I think we talk a lot about in training and education, like specifically curriculum for facilitators, but this is about integrating it into schools of social work, schools of public health, schools of nursing. Anyways, it's really great that we have 3 representatives from a New Mexico institution as a part of that cohort. And so I've been trying to find ways to integrate them into the work of the department and the subcommittees. And I feel silly that I didn't think about this committee as a really great opportunity, especially as you're thinking about, but it just was an enumerated goal, like bringing this into our state schools. I think they'll be a great resource. So unless you have a different suggestion of how to make that connection, I'll just plan to send an email introduction with those 3 folks, and then maybe we can set up a meeting, or if there's another opportunity that you think, Dan, is better for that connection, I'm happy to hear it.
Actually, I'm going to leave this to our intersessional work groups, because I feel that, I mean, through the medical psilocybin email address is the perfect way to do it. But I think that if you feel it's great to go through the intersessional group to see how they could bring that in as well, please, absolutely, especially when it comes to the research side of stuff too. Denali, I think Yeah, there we go. Perfect. I was like, I knew somebody. I was like, Danielle, I was like, if you could post it. So Denali, did you see what Danielle posted? I meant, and then Danielle's email address, and here's the link for the fellowship.
Yeah, okay, so Danielle, I should connect these faculty to you directly. That sounds great and exciting. Awesome.
That's perfect.
Yeah, in addition, on the second link that I sent, so James, Danielle, and myself all have our contact information pinned to the top of that page.
Awesome, that's great. Appreciate you doing that too, because what we're about to get into is a little bit more, because there are people that are on this call that weren't on other calls from before. And as we move into this last kind of beat, the intersessional work group ideas, I want others that are interested in getting in touch with y'all to be part of this intercession work, to come back to the next one, to know who to contact. So Gregory, thanks for putting your contacts into that. So make sure, and of course, as we go, please put your email address or contact information in too, so we can gather more. I really kind of do want to talk a little bit about some of this intersessional work group stuff, because what I'm kind of seeing is that, and I especially appreciate Gregory and Danielle, what you did today, because it really lines up perfectly with hopefully our next roadmap to really get to this work going. And I feel that as we look at it, our responsibilities for this group are kind of three. So as from my previous set of slides there, we have really a reporting framework that we need to come up with. We have kind of harm reduction, quality improvement framework to come up with, and we have to come up with, of course, the core and extended data set framework. Those three things are our main core responsibilities for this work group. And while the other work groups are working on things that are critical to standing the program up, to the propagation and the education training committee, so we have qualified, we have patient qualifications and patient safety, things like that. These three are kind of what we're looking at. But I hate to say we'll have these broken down. I really see that what y'all have come up with in the intercession group work has been, there are three things that it's sounding like. Because at the beginning I said, oh, it's education for the community, or it's emergency preparedness, or whatever it is. But it really sounds like you have a care pathway and safety kind of group. A participant experience and fit, which really lines up with what Danielle had just come up with. And the third thing, the data and reporting architecture. Both of y'all kind of came up with a lot of that as here's the stuff that needs to come back in. And I've got to give y'all a big shout out, because this helped tremendously in your work to line out kind of what the journey is for a participant, going from preparation into the session, into an integration phase, and then a follow-up, and then lastly, kind of an oversight or review, which would be what will be bubbled up from a lot of the data that gets in. And again, some of the work that y'all have done kind of showed is that there are tools that can be used along the way, and y'all have broken it down into these: are you ready, how are you doing, what happened, and is anything wrong guidance. So I think that is a perfect kind of framework to put this in. And for the work groups that y'all have, is what are the kind of shared questions to have? Is what should happen at this stage, meaning for preparation or for session or integration? What risks or concerns are at this stage? And Danielle, you broke that down actually in your presentation to kind of show here are some things that can be reported or concerns along the way, on what should be documented. Then we need to think about okay, it's documented, but what should be monitored or reviewed? And then we also, some of the first things we did in this work group were to try to create kind of a data structure, a data dictionary, if you will. But we started thinking about well, what are the core and what are the extended things? Because there are certain things that we need from every session, every participant. There are some things that might make sense in more of a research idea that might be in an extended data set too. So that's kind of one of the things I really wanted, as we do our work, to kind of focus on. So I felt that if we kind of divide it up into that, so that there is good like bright lines between the groups, the care pathway and safety, participant experience and fit, and data and reporting, that it would look like this, is that we could come up with kind of a cadence for the work to do. As that row, the first one, reporting framework, we would come up with first. And then the second one would be the harm reduction quality improvement framework. And the last one would be the true core and extended data set framework. And I felt that like the work groups can work together, all three, of course, but there would be like a main two that would be working for those things. So, for example, the reporting, the care pathway and safety, which is Gregory, what you and James Brown and really have worked on, and then of course data reporting and architecture. I'm a little weak on that one. I just don't think I have anybody at this moment for that. So I just wanted to kind of bring this up as I kind of go through this list. So Gregory, please go for it.
Just while it's on top of my head, and I'm saying this so that I remember it and it's recorded. But in the data reporting and architecture, one of the things that needs to be, I think, discovered, or like a pathway for built, is to trace long-term outcome data post de-identification through consent frameworks and like whatever else I don't know. Like there's a traditional like de-identification point where like further data doesn't apply to that individual, and if we're going to try to track people 5 and 10 years later and see if they come back and stuff like that, like how do we safely build that architecture in that context? I don't have an answer. I would like to fix that.
Thank you very much, because that would be something that would be squarely sat in the data reporting architecture group, because that's exactly right. Because we not just, I mean, you're looking at a very long view, which is absolutely perfect, but your core of that, the de-identification of data, is something that we talked about from the very beginning. We need to make sure that what we're collecting is completely de-identified, but still trackable in some way. So again, that's something that is something that data and reporting architecture committee really, or subcommittee, needs to really be focused on. So exactly. And I'm going to apologize up front on this. So this is going to be very like wordy and heavy and what I'm about to share, but it was the only way that I could think about doing it so that I could get it out to y'all. And to see it. So if you're looking at like, oh my gosh, this is unbelievable and crazy. Yes, sorry, but it's the only way that I could kind of think this through. And again, we'll share the deck, the slides and everything, like, so you can see this offline. But of course, if you're like, hey, I want to take a snap of it so I can see this offline, that's fine too. So kind of to dig into those work groups, this first one, this care pathway and safety, this is again where this is where the CATAE Pro, those kind of things kind of fit in with it. It's the mapping the journey, identifying where the risks, the safeguards, and response expectations arise. If there's anybody on this committee that's here that's like, hey, I really want to work on something like this, that you've already heard what Gregory had kind of posted from the intercession work. This is somebody that's really strong in harm reduction, somebody that safety-focused clinicians would be great for this kind of group to be part of this, and people familiar with crisis response adverse. I know that we were just talking about that Eileen had to jump off, but Eileen comes to mind on this one as well. Main questions this group's going to have to answer is, what are the key risk points along preparation session, integration, and follow-up, which I think y'all have already been working on. What safeguards should exist at each stage? What events should be documented? What requires escalation, of course, going from challenging to adverse? And what patterns should trigger review or change? And so that kind of last bullet is probably a longer conversation, but is something to be mindful of. And so there's some specific deliverables I feel that the group can kind of come up with: this care pathway map, a safeguard map, event taxonomy, those kind of things that make sense in that kind of like the work that you're talking about, Gregory. This is where I try to break, that's why I said it's going to get a little wordy, but what I wanted to do is break down each one of these kind of three groups as to what they'll be doing. And the reporting framework, the harm reduction quality improvement framework, and the core extended data set framework. So again, like I said, those are our three kind of deliverables this group needs, our RICI group needs to look at. And so each one of these work groups kind of defines a set from those three. And that's where I wanted to kind of show is like, okay, what can we do in this work group to bring in certain things? So I think that what you're already doing is exactly in this direction. And so, for example, finding event tiers, whatever protocol that you use, if it is the PATAE or the CATAE Pro, looking at event tiers, like this is just a routine, no incident, all the way to serious adverse event requiring external response or formal review. So that's, I know what y'all are working on. So that's where your question as to what protocol do we want to utilize, I really feel this is where this work group gets to say, this is what we're going to do. So whatever that kind of comes out to, I don't want to be the one that says that's the one to use. I feel that this work group needs to be able to say that. And I think y'all are well equipped to be able to make that recommendation to our whole work group for that to move forward. And this would include any of those screening tools, anything that you've already been working on and looking at in the research that makes sense from this. And then, of course, to kind of bubble up those things down toward the bottom of this column, system integration or system learning questions like, are certain harms happening repeatedly? Emergency transfers clustered in certain settings? Are consent and PrEP reducing preventable distress? So those kind of things I feel can come up with that kind of safety that are already out there in the clinical practice groups or the patient safety groups. But really, this kind of work group will be talking a lot about how do we monitor that and report on that. The second work group, that participant experience and fit, and a lot of what Danielle has been working on, talks about like what must be captured about participant preferences, boundaries, respect, cultural, spiritual fit, affinity, and participant reported harm or mismatch. So everything that you had talked about today really fits into this. The best people to work together on this work group will be people who are strong on patient-clinician affinity, focus on multicultural competence and patient-centered care, and then, of course, attentive to respect boundaries and mismatch issues. And so the main questions this group will be talking about is what participant preference should be asked about, does a good fit look like? And of course, when we're talking about this, is like we already have education and training committee. This is talking about what kind of data can we look at here as to, or are we tracking good patient and clinician affinity and fit? So this is where, just like Danielle talked about, is like there are tools that can like, is the participant feeling safe and heard and respected? Is there a cultural or spiritual mismatch? Those kind of things. And how does it look from the provider or the patient entering or providing this information as like a low traction. So we don't want this to be something that's onerous to either of them, but something that it would look like. And then this one kind of really fits in a lot of the harm reduction and quality improvement framework. So this one's a little bit longer in this work group of what they're going to be looking at, like are participants reporting that their preferences were being ignored? Are there patterns of anything? Which is perfect, kind of what Gregory brought up about somebody's bias might change the outcomes of their sessions. And so there's some quality improvement sections like, what do we do? Could we help provide recommendations for the consent content or facilitator training or anything like that? And then, of course, patterns that could trigger like referrals over to our Equity, Access, and Cultural Considerations Committee. So those are some things from that. This goes into now a second set, which is the data. So the data that this work group might recommend is like, what can we collect in a data system? And of course, it has to be something that could be collected in a data system. So I want to kind of make that note there, is that this is the work that we'll have to work together on this work group and the last work group, the data and reporting architecture. And this work group at this moment, I feel for me is like, this is the part that I just don't have a lot of other people working on right now. So I'm going to say for me is like, this is one that I will ask for some help on. So if there's anybody out there that feels like, hey, I'm really good and strong on the data reporting and architecture concept, this would really be very helpful to, at the end of this, to kind of say, yeah, I could help with this. Because these are people that are good with databases, who are systems thinkers, operations, can distinguish between what's ideal and what is feasible. So what Gregory just mentioned about like this long-term de-identified thing, this is exactly what these individuals will be helpful for. And this group's going to talk about what is the core data that we need to collect versus what's the kind of extent that would be great on research. There's going to be a lot of things that come in qualitatively instead of quantitatively. So how can we capture some of that in a data system and then report out on that as well? And what should be structured for reporting and oversight, and what should be aggregated for review. So these would be things like that data dictionary and those kind of things that come from it. So there are some work that gets done together for reporting framework and harm reduction, of course. And some of them, for example, dropout rate was on here. I remember we added that into our data dictionary, but what are some of the patterns we're seeing? Are we seeing mismatched trends, disparities against certain groups or ethnicities or race, and is there site-to-site variation? And this one's the big one because there's so much data that has to be kind of collected in this, and so that group is really responsible for that. So I just, really want to just throw this out here is that there's a lot I know of work to be added into this, but I want to go back to this and ask everybody is like, do you feel that this kind of structure that I've put together here is helpful for the next set of directions for this group? And like I said, I apologize for giving so much, words out here, and I'll drop it into chat and of course we'll post it. But I just wanted to ask, is this helpful moving forward? Again, to show that these are the three kind of committees that the work groups for intersessional work. And so you can raise your hands and throw slings and arrows at me to say, wow, that was super complicated, but I just felt it made a lot of sense to say, here's, instead of calling it adverse and challenging events, intersessional group and patient quality. So this kind of helps to say, where can we fit in this? So I just wanted to ask that, and I'll drop in to the chat also a link where you can find this information too. So everything that I've kind of shared with you today, I hope that you'll be able to see it even offline. There it goes. So please feel free to open your mic, raise your hands, let me know what you think. And especially if there is something that you wanted to say, like, hey, I want to be working with that group, because again, you've got some awesome people. You've got already Gregory Evans, who's been really on the care and pathway and safety. And then of course, Danielle has been focused on the participant experience and fit. But like I said, I don't really have anything for data and reporting architecture. So oh, Danielle Leonard, yes, I would like to join group 3. Group 3, the data reporting and architecture group, Danielle?
Yes, that's sort of my area. I just sort of segued off into multicultural when asked, but yeah, I do research and do work with statistics. So
I love that. Yes. Well, I don't want you, because one of the things that we had talked about was that it's very difficult to have like doing all the same thing, so I want to make sure, Eileen Brewer seems to be very, see, I'm volunteering, she's not even here, but something on the participant experience and fit, you've already done, the yeoman's effort to get that started. So do you feel that you want to or do you want to, you'll be working across both, of course, but do you feel you want to be like a strong lead for data and reporting architecture? And if you say yes, that's fantastic for me.
I'm just really interested in how we're going to do the battery. I'm really aware of participant burden. I think that we probably need to try to come up with something for 30 minutes. We could do, we could do work with branching and skip logic and branching logic and stuff to try to get there. And I'm also just aware of the measures and the validities and alphas and sort of into that.
Yep.
But I'm happy to jump in on the fit as well, because I am a therapist and I care deeply about that.
Well, as you can see, is like, at the bottom of this slide is that's exactly, there's a lot of overlap and affinity to work. It's just there are this time, this kind of group stands out and to do some of that work. And there is the crosswork there. So appreciate that. And I just want to hit something in the Catherine Warnock. Thank you. I can help with groups 1 and 2. Absolutely. Thank you very much. Because that's going to be super helpful on that. Ian said, hey, I've got to head out. Appreciate the work everybody's doing here. And then I saw Gregory had his hands up, but now it's gone.
Well, let's see. It looks like we've also got Lisa Ginsburg with her hand up. And
sorry about that. I did not see Lisa down on there open. I had my menu over it.
No worries. All right, Lisa, your mic is enabled. You can unmute when ready.
Thank you. Thank you for this information. It was really helpful. I'm happy to offer support for all the groups through our team. Would love to hear how often they meet and how much time and commitment would you require for this?
So I'm going to throw this one up here real quick because this is kind of our cadence that I've already kind of blocked for us to have report outs. So for our this group's next meeting would be June 12th, followed by July 10th and August 7th. And so the intersessional work happens between that time. And I'm going to let I think that Gregory might have his hand up on that one to probably answer that as well, because he can probably give a little bit more, conversation about how much work is to be expected kind of offline, how often, because I do know that y'all probably have visits as well. So.
Yeah, I mean, I don't think it's really established. I think James, Danielle, and I kind of targeted meeting as we could. We maybe meet once or twice between meetings. And I think we do independent work between that. And some of the, how much effort is it comes with your background and your expertise, because you may have actually worked for 20 years to gain the knowledge that you bring to a 1-hour meeting. So as far as our experience, it's been a fair bit of work. I kind of collect a lot of the data and present it and create the hub of information. I'm a glorified secretary, I think, in that respect. But I did want to say I was hoping more data nerds would raise their hands, but that is my core functionality in this world is data architecture and program management. So I'm not going to let you be alone on that, Danielle. I'm looking forward to getting into that. I also was curious if, and I know I've asked this, I'll continue to ask if the department has any forward movement on the conversation of what that looks like, what their needs are for that engine, if that question makes sense.
Yeah, I think that will be a beneficial question, because if there's anything from maybe Dominic, if I'm going to put you on the spot, if you're out there, if there is anything the Department of Health wants to kind of talk about any kind of data governance structure, database, I mean, whatever you want to talk about, because that is going to be our next kind of thing to jump into.
Don't say do it.
Right, and thank you, Dan, and Greg as well. And the answer to that is no. That's actually a part of what all of this is really about, is to help determine what type of data is necessary and what really is going to help balance between, for the difference with ensuring patients are getting served and not experiencing survey fatigue or data collection fatigue, for example, and what actually would fall in under research categories. So once there is funding for various research projects, what types of projects should be, what data should those projects be focused on? And that's actually a part of what we're relying on this committee and subcommittee to really determine. And we don't want to try to direct it and say, this is exactly what should happen, because anytime that occurs, we end up missing things. And we don't want to do that. We would like to have that broad base to start and then start narrowing things down based upon the other aspects, whether it be funding, budgets, timelines, things like that. But right now, it's really broad and open at this point in time.
Thank you for that.
So, yeah. Does that, I mean, I don't know if that kind of gets to the crux, what you're looking for, but I think that could be the recommendation that we could put out there too.
No, I think that's great. That's a good place to start. Open field.
Yeah. Yeah. So think of it as something where y'all can, from y'all's intersessional group, to be able to say, here's kind of what we make that recommendation that we utilize. Let's go down that road.
All right. And Brenda?
Yes, thank you. Well, this was a lot of meat and potatoes here. I really love seeing all of this because I love data too. I really love all of that. But as a clinician and actually part of like chairing the education and training, I would like to see like a mock-up of just what we need to collect as therapists in for our clients. And it's like what Dominic was saying, we don't want to be fatigued from collecting all of this information, but geez, all this information is vital. It's like, oh, we all need this because this is how we're going to be able to move forward. But maybe having something that's manageable and concise with collecting this data, and also like feeding that data into a program where you're going to be getting the stats correct that you need in order to provide future research on this.
And I'm going to jump in on that too. You're exactly right. The whole idea for this is not to say collecting data for data's sake. The idea is honestly continuous improvement, and not on our side, because I don't want it to be something where practitioners are utilizing a data system in which they only hear about it whenever bad things take place. The whole concept of this is, how can we implement this on a quick turnaround so that even the practitioners in the field are getting good actionable data about their practice, their patients, and that's the true continuous improvement. So again, I would love this to be like, if you're putting, as a clinician, information into a system, that it is coming back to you quickly for continuous improvement in your own practice. That's my feel on that too.
Yeah, and programming this is very well, I've worked with a lot of programmers, and what happens a lot of times, they get into their heads and they're going, oh, this would be really great to put this in, and then it doesn't really relate, or it doesn't really it's not vital information. So having somebody that really knows what kind of material that we need to collect is really vital with all of that.
Absolutely. Thank you. That's very true. And also, I should say, I want this to be actionable for the participant as well, so that the participant knows that they're actually on this journey too. So I'm going to jump over real quick into Lisa Ginsburg. What's the best way to connect if we want to offer support? And Gregory Evans said the above link summarizes the time impact across pathway collections in plain language, which is extrapolated from Danielle's input from 410, the RACI meeting, which is true. It's like, I know that work group really worked on trying to say that here's what it looks like, and time-wise, not a long time, but just a short amount of time. So there's a little bit of that mock-up you asked about in that above link that Gregory posted. And Eileen says, I'd like to help out with group 1. Thank you, Eileen. So Gregory, go ahead.
You always do that when I'm typing on the other screen.
I know. I used to work food service, so I'd come around whenever somebody had, you know, like taking that bite. So that's what I do. I think the first thing is
I'm pretty sure I lost my train of thought. I'm distracted.
It's okay. I think you were typing in probably to respond back what Brenda was talking about, because I saw your hand go up right at that same time, and then you did type in that there is some information there. For Lisa's question, make sure that Lisa, if you do want to offer support, just kind of say your email address and probably the chat and what group that you're interested in, whether it be the safety or the patient fit or the data. Kind of like what Eileen did too.
Yeah, to Brenda's question, a lot of that is outlined in the link that I posted. Danielle did an extremely detailed assessment of time cost on what instruments, and then we separated it out into pathway impact. So if a person is going through one of the 4 pathways of treatment of qualifying conditions, there are certain things that are universal that should be tracked, and certain things that like are more pathway specific. And then there's other events that trigger certain types of data collection or additional instruments to be accrued. I'm looking for another link, and I'll post it just below this that has more of that breakdown in detail, which I think might help understand. But really, I mean, it's like over the course of 4 months, we're looking at a couple of hours, and it's the clinician's job to collect data, and clinicians tend to be, used to that sort of thing. And without like revealing too much, I think that there will be potential for tools being developed that will minimize the impact and streamline the data collection on instruments through, a handful of to be defined tools. I have a plan.
Thank you very much. And Lisa, I know that there was a document that was shared for contact information, but feel free to drop your, like I said, email into the chat, and I'm sure they'll capture it to reach out to you. And Eileen, I know they've got your contact information as well, so you can be on that kind of intersessional work as well. So, like I said, appreciate the help on all of this, number one, because this has been so instrumental in kind of moving us forward. The idea, like I said, for our next meeting will be June 12th. And at that time, I would love for the intersessional groups to be able to kind of put out that reporting framework consensus, whatever that might look like. And remember on that is that I've dropped it in that link into the chat, what might look like. Kind of go back through my slides to get to that. So when we talk about reporting framework, these were some of the things here. I don't think you could see my pointer. So this is kind of the reporting framework from the care pathway and safety group. And this is the kind of reporting framework that comes out from participant experience and fit. And then from the data reporting, this is the kind of reporting framework. So it would be a great thing to be able to kind of combine all of y'all's work and present that on the June 12th, because then that sets that framework that everything else can kind of fall into place from that. Again, all 3 intersessional groups kind of work together on their own thing during that time, but they're reporting back for this first part for the June 12th. And then after that, the July 10th would be then bringing up, here's the harm reduction and quality improvement framework, and bringing that consensus to work. And then the last one, of course, the 7th of August would be the core and extended data set. So that's really where we can make that big recommendation as to here's what that data set might look like. And then I've also reserved the September 11th meeting there, and it just says to be determined. So I just wanted to be that as like whatever might need to be kind of hangover work, that way we can get that. So that way, for our next meeting, June 12th, we won't be talking about a whole lot of stuff. We'll be just talking about this one thing, reporting framework consensus. So everybody that's on that call will hear from the intersessional work groups reporting out what they feel the reporting framework would look like. And we would then come to a consensus at that time to say, that sounds great, let's solidify that, and we'll move on. So that way the groups can work on the next thing, harm reduction, quality improvement framework. Again, we'll make consensus at that meeting, and then that way we'll move on to the data set. And then once we do that, we can kind of set that in place. So that's where I just wanted to say is like, please, make sure that if you're interested in that, you're kind of looped in and connected. You can always reach out. And of course, Jonathan put in the chat, you can find the sign up for committee meetings here. And there's a link for that. Gregory Evans posted the time burden estimates. So that's kind of where I want to kind of get our, like I said, our cadence moving forward so that we'll now start to build out our kind of voting and making the recommendations out to the board as a whole as we go through this. And I think that way, if we're ready by the September 11th, then we'll actually have some data components ready, because if January 1 comes around, we'll have to have a data system set up and established along with the patient harm reduction, quality improvement, and reporting for adverse and challenging experiences and such. So that gives us, I think, a really good thing that we can work on independent, but in conjunction with some of those other work groups. So would love to hear, I mean, if you feel that that's doable, if you feel that's insane, but I would just love to hear some of that on there. Also, for the group 3, these are some of the things that we had talked about before. I'm just jump back to some of these quick slides here. The data collection system. These were some of the things that we have worked on as a draft from some of our previous meetings. So that was also in the link that I threw in there. So these were some of the things we talked about, and feel free to utilize them or to take them in a different direction as y'all go too. So. And so at this time, just want to make sure that you have all the information already put into the chat, of course, how to send public comments here. So you've got that information in the chat as well. I also want to leave this last bit of time for y'all to have any kind of public comments. So this is now, I will stop talking since I've shared most of that stuff myself. And so I want y'all to be able to open your mics up and kind of share anything that you would like about the work, anything about our next steps, things that we need to look at. Feel free. So please raise your hand. We'll unmute your mic. And we've got about 15 minutes left of this session. So you've got plenty of time.
All right. Let's see. Jay Webster. Sorry, I forgot your first name, but your mic is enabled. You can unmute.
Thank you. Can I ask Gregory Evans to please repeat? I wasn't familiar with the acronyms. I believe they're reporting framework models that are being decided upon. I think it's very important that we can differentiate between a concerning event versus an adverse event. Which one of the frameworks would allow us to make that distinction?
Yeah, that's a great question. It's a lot of letters that all sound the same. So the CATAE, the AE part stands for adverse events. So cancer, something, something. Danielle. I can't recall. But basically, the CATAE is an oncological reporting structure for adverse events in treatment of cancer. It is kind of a broad standard across multiple industries because no one has built an instrument as effective as that. They made a pro version. I don't know what pro stands for, but essentially the PRO dash version of that is an instrument that can be adapted by any program without going through the process of developing a new framework, becoming an instrument, codifying that into the lexicon of whatever says that an instrument is an instrument. Now, there is a researcher out of Emory University named Dr. Politsky who developed a framework, not an instrument, a framework called PATAE, which is psychedelic assisted therapy adverse event tracking. One of those first links that I posted, all the knowing flight is just what my notes program publishes as. So in there's detailed information about how the PATAE can apply to our needs. Ooh,
And
thank you, Daniel.
Yeah, I was just going to say, Danielle, common terminology criteria for adverse events. And to that question that you had as well, is that, as you said, is like the difference between what's an adverse event, reportable, what's the difference between a challenging event. It really comes down to exactly what the patient's, the safety kind of work group gets to talk about, is like, these are things that are reportable events that would be on that protocol, and here are things that are just challenging events that are duly noted and part of session, but not as part of, for lack of a better term, a red flag that might come up. So that would something like that. So again, that's part of this intersessional work group to say that off of whatever protocol is chosen, here's those items that are definitely reportable and actionable.
Yeah, and to cap that, the recent so it is a framework that Politsky et al. Has developed. It is in version 0.1. So they're like they're publicly saying this exists. It's out there. We don't have a final product, and our goal is to connect with their team to see how we can either fast track that if they already have the pathway towards becoming an instrument in place. That can take like 1 to 5 years. We don't have the time needed to develop an instrument, but we want to be able to utilize and leverage the information in that framework by modifying the pro CATAE as a stopgap to allow us to be able to understand and define the difference between challenging and adverse events. Does that answer all your question?
Very thorough answer. Thank you.
Cool. I've read way too much about that. Oh, there's a Canadian study on end-of-life care, palliative care, that is utilizing this framework, and it is in process, and I'll find a link and put it in there. It's an incredible study. I love the Canadians, but yeah, it's a wonderful application of this framework.
All right, and I see Hanifa's hand up, and you can unmute when you're ready.
Oops. Hi, can you hear me?
Yep.
Yay. Okay, good morning, everybody. Wonderful meeting. I'm so happy to be able to attend today, and thank you, Gregory, for making the announcement at the last end of life committee meeting about this meeting and the contents of this sort of cross pollination, which is super important. So I am the co-director of the Psychedelic Mental Health Access Alliance. We're a national organization, and we're doing some of our first pilot studies and work here in New Mexico, which is super exciting, partnering with Dr. Larry Lehman for the group Psilocybin Assisted Therapy for PTSD study. As a part of that, and it's something that Gregory also touched on, we are piloting a tool that we're calling the Circle of Care. And it's just something I would love for this committee and really all of the committees in the state to think about, that continuum of care that might be happening outside of the clinical protocol, but that is absolutely essential and important toward actually harm reduction. So when you have ongoing integration support, you're going to see a less likeliness, right, of harm happening, of people moving into difficult spaces alone. And so offering up, I would love to know, when you guys are talking about these adverse events and tracking these things, like what is the time frame by which you're speaking of? Is it within a certain amount of time after the last integration that's a part of the clinical model? Does it extend past that? And would love to think about how can this committee help PMHA come up with some of the data points that we should be tracking in terms of the effectiveness of an ongoing integration support model. Thank you.
If I can respond to that, I think you might have a little bit more insight into this than most people, but I don't think a lot of frameworks and studies are tracking adverse events after the outside of the dosage experience. And it really is groundbreaking to just think of the idea of holistic lifelong care. And so I'm all for it, and I think you're well aware that I'm here for the idea room. Yeah, I'm not going to ask you to commit more of your time to this world of developing tools than you're already committed to, but your insight is is welcome here.
Thank you.
That's a wonderful thing that I say about this group is that if you come into it and you say, hey, I've got something, and then you're part of it. So because your expertise, that's the whole point of this group, is the expertise of everybody. Everybody has something to share. This is, I keep saying, is I'm a conductor. Y'all are the actual orchestra that are the ones that are super trained and super experienced. So I'm just happy to be part of the group. So if you can share, please do and be part of it. So I don't think that anybody right now is saying, here's exactly the way that we're going to do it. Everything is kind of ability to be flexible. So please know that, that you're welcome at this table.
Thank you so much.
And Brenda,
Yeah,
you can go.
Yeah, I just wanted to kind of look at that for just a moment, and the long-term data collection on that. And all of this is great, but all of this costs money too. So, but if we could, have something like that as kind of placeholder to look at, as far as, because yeah, no one's really looked at the long-term effects. And it's like, I think, like, I'm going back to a study that Matthew Johnson did with smoking cessation, and I think they did a follow-up, I think after 2 years, and that was still robust. I mean, people were still not smoking after psilocybin treatment. So yeah, we're looking at like funding for long-term, either adverse effects or positive effects, and seeing what that looks like, because I think any one of us who have had experiences with psilocybin, or good or adverse experiences, yeah, we still continue to feel that long after it's been administered, and you've had that experience. So I just wanted to throw my 2 cents in about that.
No, perfect, Brenda. Thank you very much. And in the chat, Kate Talk had said, in my experience, most serious adverse events show up in the days and weeks after the psychedelic session. Glad we're looking at this. So yeah, you've definitely, it's a perfect thing to bring up. So thank you. We've got 5 more minutes left. Is there any other comments that anybody would like to make?
Can you hear me? I just want to jump in and say that the Circle of Care pilot, it will be a part of this group psilocybin assisted therapy pilot. So we're going to run it for 3 months after each cohort finishes their 15-week protocol. So we will be collecting, both qualitative and quantitative data on its impact. An important thing to also lift is that the services and resources will not only be available to the participants, but also to their families and loved ones, to provide them with support and skills and training to support their family member that's just come through this treatment. Thank you.
Thank you for sharing that, Anita. And then Gregory Evans in the chat. Yes to positive effects. One of my primary interests is continued research on the window of plasticity and the frameworks that allow care teams to support that over time. Well, I cannot thank everybody so much for a wonderful meeting. Like I said, I really appreciate us to be able to kind of come together on that level setting for where we sit in our committee and where we can help out in the roles of other committees and where our role and fit really are, and the work that's going to happen now for this next set of sprints that we're going to be doing for the next one coming up on June 12th. I really hope that y'all are able to make it to our June 12th meeting so that you can hear from the intersessional group reporting out on what their reporting framework will look like. And I cannot, like I said, thank y'all enough for being here and spending your time, not just at this meeting, at the other committee meetings, and also as part of this intersectional work, because I know that it's a lot of time for everybody, but cannot thank you enough for sharing your expertise to building an amazing, safe New Mexico medical psilocybin program. Don't forget that there are additional work groups that are going on. Brenda's is coming up later this afternoon for education and training, so please make sure you register for that. And that way you can come to the next group later today. So otherwise, thank you all very much for your day. Have a great weekend. I really appreciate it, and hope you get to have a wonderful one. Take care.
And I also just want to say the Brenda's meeting will also include the End of Life Care Committee. So those two meetings are together today. Yeah.
Combined. Thank you. Perfect.
Yes. Thank you, Dan.
Perfect. Thank you very much, Gregory, Danielle, everybody that participated and shared. And I really, like I said, it's fantastic, Eileen, for your help, everybody out there. So thank you all.
And thank you, Dan, and thank you, everybody. I hope you all have a great and safe Friday and weekend.
Happy Mother's Day as well.
Yes, absolutely. Thank you, DOH team. Thank you all. Have a great rest of your day.